So when we did the biomechanical assessment, there's a few different options when we're looking at what kind of glide is going on at the AO and AA joint. So this is there's a double intent behind this particular lab. One is for you to feel the glide of the joint, but number two, these glides are what you're going to use for your mobilizations. So when we're looking at a restriction in right rotation, and if Ray had a restriction in flexion and right rotation, I would assume that that right joint isn't going backwards. So what I would like to do is check the glide, because a restriction is either the muscle guarding or the joint is restricted itself. So what I can do is actually take C1 and glide it forward on the fixed occiput, which is a relative posterior glide that we were going to get at that joint. For all of these, if for a right rotation, the glide for the ipsilateral joint's usually on the bottom part of the joint. The glide for the contralateral joint will be on the joint or the more normal motion. So in this case, I'm going to find C2. Then I'm going to slide up to C1, and remember, C1, angle of the mandible mastoid process, C1 transverse process on both sides. So I'm up on C1. And have him turn this way a little bit. So then when he rotates to me and I get to his barrier, I can gently come in and fix the head. So I'll do it this way. You just need to fix the head. You can do it this way too, but if you're female, you may have to just come into the side and get in this way. So then when you fix the head, I can just gently do this with my hand. So I'm just taking C1 and trying to push it from below, which is stressing that right joint or checking the glide on the right joint. When you're checking a glide, you're just trying to feel this. And you're like, heck, Terry, I can't feel that. I can't feel a bee's knees bend. Well, neither can I. But what we can do is just see if there's a sense of motion, because you know you're at least, that tension on that area is sending great input to the patient's central nervous system. What I can have Ray do, though, is I can have him gently turn into my shoulder like he's turning to the right, which is the motion we're trying to regain. So go ahead and gently turn and relax. When he gently turns, I can see if I can get a little bit more rotation and see if I can glide. Now, if there's no pain involved and it's just a stiff joint, you're having a great day, because then all you can do is just do a nice sustained hold here for 20 or 30 seconds, and then go ahead and push into me and relax and see if you can regain the mobility at that joint. So for this particular mobilization, I biased a little bit of flexion and rotation to the right. I would check the glide. If I felt there was no glide, I would do a sustained hold. If I do that neuromuscular re-ed and I pick up a ton of motion, it was probably the muscle. If it was the other joint, that means my mobility testing had extension and rotation to the right. I know that that joint on the contralateral side, that left joint, can't come anterior. So then I'll extend him, rotate him to the right. Again, start at C2, slide up to C1, but this time I'm fixing the bottom segment at C1, and then I'm gliding, seeing if I can feel a glide forward. If it feels stiff, I can be like, okay, go ahead and turn gently into me, right? Good, and relax. And I'll see if I can pick up more motion. After a couple neuro re-eds, if that still feels stiff, I haven't picked up motion, then it must be a stiff joint. So then I can hold that for a while and do a sustained stretch. Patients really like this. You get good, especially once they get into their 60s and 70s, these joints are just stiff, and any mobility here will help out that lower cervical. The AA joint, same hand placement, just a slightly different plane because it's a convex on a convex surface. So for this time, there was no change with craniovertebral flexion or extension with that rotation. So then what we can do is I can find C2, go down a segment, and now fix C2. So instead of fixing C1 like I did before, I'm on C2. I tend to stand like at a 45-degree angle from the shoulder. It just makes it easier for me to come in and fix. Now, if I have a restriction, I take him to the restriction and I think it's AA, I'm going to take C2 and push it up and forward, which is a relative down and back of that joint. So it's the same thing. I'm going from the lower joint, the C2, and pushing it up in C1, simulating C1 coming down on C2 on that side. So here I am, I'm at the barrier. I'm like, do I feel a glide? Oh, I don't know, maybe, maybe not. Let me see, go ahead and gently turn into me and relax. And then I'm pushing up. And if it feels like it gives a little bit, oh, okay, well, maybe that was just more of a neuromuscular thing. So go ahead and turn into me again and relax, and we'll see if we can take up the slack at that joint. If it's stiff, stiff, stiff after a couple contract relaxes, then I will sustain that and move that joint. So that was ipsilateral AA. Contralateral, C1 can't come down and forward on C2. Same hand position, start at C3, come up to C2, go into the rotation. Now my bias is on this joint. So it's going down and forward. So go ahead and push into me and relax. And you see if that can come down and forward. So again, if you have angle of the mandible, you're on C1, you're behind C1, you take up that soft tissue, you're fixing C2, and you're coming down and forward. So go ahead and push into me and relax. And then you see if it continues to be stiff, then you hang out there. If any of these reproduce the pain, you're going to have to look at pain in relation to the barrier and decide whether you're going to just do traction or graded mobilizations. But before you do that, see if you can find something else stiff in that chain and mobilize it. Because if you start fiddling around with a painful joint and reproduce the headache and you haven't looked to address posture, breathing, stiffness in the thoracic spine, then you're just irritating this, and this is just a tissue that's, the range is being borrowed from too much because there's another area that's not moving efficiently. So that's mobilization, same hand position, AO, AA, just different emphasis based on the biomechanics.